Right. So now, as I said, guys, all of these mechanisms which I have developed in form of a flow chart, they are a result of reading lot of various research articles and textbooks, then synthesizing and summarizing the information in the simplest manner possible. Okay, that's why some of you may complain, oh, why is she giving handwritten notes? You are lucky, because if I give you these research papers to read and say, oh well, good luck, it's going to be very tough at this level. Okay, especially when all of you, most of you are learning these conditions for the very first time. Okay, therefore you have these handwritten ones, and it is very difficult for me to make this in a Word document and all, but I have tried to write it in as nice handwriting as possible. I know I don't have great writing, but come on, this is like good writing. Okay, I mean, this is not that bad. All right, so guys, basically you have three main mechanisms for alcoholic liver disease, ALD. Okay, so now, as the name suggests, this liver disease is happening because of excessive consumption of alcohol over a prolonged period of time. All right, some people may not be consuming alcohol, say for 40 years, and they may still get this disease. It could be genetic susceptibility. Okay, so a lot of variations as to why some people may get this, and some people who may be such chronic alcoholic individuals and they may never get this. A lot of genetic susceptibility plays a role, but we want to see if an individual gets alcoholic liver disease, then what happens. All right, so yes, if an individual gets alcoholic liver disease, there are three main mechanisms which are happening. All right, so if you were to write this answer in your exam, yes, you would be expected to write all of these three main mechanisms. Okay, now I have, what I have done in your coming slides, I have taken one mechanism and gone into the detail of explaining it to you. Okay, then I have taken the second one, then I have taken the third one. All right, but in your exam, you can write it like this, as you know, this one comprehensive flow chart. All right, so that is what I want to say, that in your exams, write it as one comprehensive flow chart. For teaching purposes, see, this is how I have, like, you know, broken down the mechanisms. Okay, so this one over here, which is the next slide to this one, this starting from acetaldehyde, this is this mechanism. Okay, you see my mouse hovering, so this is on the far left side. This is the mechanism. After this slide, you have the NAD and NADH plus, so this is the center one, and similarly you have this intestinal changes, and that's your third one. Okay, so I hope that makes sense. So basically it is the same information in 3 slides, but I have, like, you know, means given a bit more space and, like, you know, means made it a bit more visually easy to read. But yes, once you know what the science is, this is just to give you an example. This is how you can represent the flow chart in your exams. Okay, because in your exams, as you will see when I give you instructions, I give very clear instructions that write your answers in flow charts and bullet points, not these wordy 6-page paragraphs, because whatever I teach you is like science, A to B. You don't need to be fluffy about it. Okay, come to the point. If you have your points right, you get the mark. Okay, so we'll talk about that later, but I hope you get the essence of it. All right, so yes, going to the first mechanism of your alcoholic liver disease, acetaldehyde is toxic. It is not good for the liver, human liver cells. Okay, so yes, your acetaldehyde, the compound which is produced during the metabolism of, say, during the breakdown of alcohol in the body, produces acetaldehyde. Acetaldehyde is toxic. Why it is toxic? Because it causes mitochondrial membrane damage. Okay, so mitochondria, the powerhouse of your cell, the membranes of the mitochondria are damaged because of acetaldehyde, which is not a healthy thing. Okay, so yes, so what do you have when your mitochondria is getting damaged? Then you have inflammation of your hepatocytes. So the cells of your liver, as I said, they are called as hepatocytes. All right, and these cells have mitochondria. So say within the cell, the mitochondria is sitting, which is getting damaged. Therefore, the cell is now facing inflammation and necrosis. Okay, because your mitochondria is damaged, the immune system obviously automatically gets triggered. When your immune system gets triggered, you have inflammation of these hepatocytes, and finally you have necrosis and death of these hepatocytes. Okay, so your hepatocytes die because your mitochondria is the powerhouse of the cell. When the powerhouse is dead, when the powerhouse is not functioning properly, how is the cell going to live? It is like, you may not believe in this, but obviously I come, from a Indian origin. So soul. So mitochondria is like your soul. If you don't have a soul, you have a lifeless body. Okay. So it has, say, similar analogy. So when your mitochondria gets damaged, you automatically have inflammation and necrosis of the cell, because the powerhouse of the cell is dead. Okay. It is destroyed because of acetaldehyde. Okay. So I hope this logic makes sense over here. So now what happens when you have, say, inflammation and necrosis of your hepatocytes? There are physiological, histopathological changes in the cell structure. Histopathological meaning morphologically, the cell structure changes. The healthy liver cells, they look lobulated. Okay, so lobulated is like a lobe, like, they are a bit elongated, all right? But now they look nodulated, and they look all clumpy. Okay, they look like little knots. Okay, so now they look nodulated. Unfortunately, these nodulated liver cells, they have poor functioning capacity, meaning a healthy individual like you and me who has a healthy liver, we will have good functioning capacity, but nodulated cells will work, say, 60 to 70% less capacity. Depending upon how much nodulation has happened, the liver functioning capacity keeps decreasing. All right. So now this leads to all of this, because you have inflammation going on over here. This leads to alcoholic, where you have hepatitis. Okay, so you have alcoholic liver disease. So you have alcoholic hepatitis. So guys, as I said, your ETOH is your chemical formula for alcohol. Okay, so some people ask me, what is ETOH? That's your biochem. Okay, so it is alcohol. All right, so it's easier to write it rather than always keep writing alcohol. Okay, so yes, you have alcoholic hepatitis happening because you have inflammation of these cells. Inflammation of these cells, meaning the lobulated structure is dying, and the new structure which is forming, they are nodulated and they are not working very well. Okay, so now we go to the second mechanism. So all of these are happening comprehensively. Okay, so all of these are happening together. So now guys, again going back to your diabetes lecture, in your alcohol breakdown in the body, you had NAD, which is getting converted to NADH. And individuals who are chronically drinking over a prolonged period of time, and they are drinking a lot of alcohol, meaning lot of NAD is getting converted to NADH. All right. So now in this case, what is happening? When you have NAD, which is getting converted to NADH, I'll hover my mouse around it so it's easier for you to follow. Okay, so you have high fatty acid synthesis in the liver. Okay, so your endogenous production of your fat increases. All right, so your VLDL, for example. All right, so you have lipogenesis happening. Okay, endogenous production of fat in the liver. And in contrast, you have less breakdown of fat for energy. So less beta oxidation. All right, and one of the key classic signs of difference is, if you remember your diabetes lecture, you had ketone bodies formation, and therefore you have ketoacidosis happening over there. In liver condition, the alcoholic liver condition, because you have less fat breakdown for energy, you have less beta oxidation, you actually have less ketone bodies. Okay, so you do not have ketoacidosis happening. All right, so but unfortunately, you cannot take fat for energy purposes. All right, so you cannot take fat for energy purposes, and you have excessive endogenous production of fatty acids. All right, now this leads to increase in triglyceride synthesis, VLDL synthesis, and accumulation of fat in the liver cells and around the liver. All right, so this is what leads to fatty acid accumulation. This is called alcoholic steatohepatitis. You know, have you had non-alcoholic steatohepatitis? Same thing over here. You have endogenous fat production, and therefore you have alcoholic steatohepatitis. Steato, again, standing for fat. All right, and hepatitis, as I said, you already have inflammation happening at this stage. Okay, so you have alcoholic steatohepatitis. Okay, so guys, this is how you remember these scientific words, these medical terminologies. Okay, rather than just by hearting it, remember, try to understand the breakdown of it. Okay, so alcoholics, steato meaning what? Hepatitis meaning what? Hepatitis has two parts to it. Hepatic meaning liver, and tis meaning the inflammation. All right. Then you have, on the other hand, of course, the conclusion is what? The conclusion is hyperlipidemia. Why hyperlipidemia? Because you have excessive endogenous production of fat, okay, in form of your triglycerides, in form of your VLDL. So yes, your blood levels of, say, fat, which is cholesterol, triglycerides, VLDL, everything is high. All right. Then you see you have increased blood lactic acid. All right. So you remember how in gluconeogenesis, when we spoke about the diabetes lecture, you have a opportunity, if we had NAD in the first place, you have lactic acid, which can go into the gluconeogenesis pathway. All right. And then it can say give you glucose, and this glucose can give you, say, energy and things. But over here, that doesn't happen. Why? Because we don't have NAD. Okay, so lactic acid is not going to generate energy. Unfortunately, fat cannot generate energy as well. Okay, so lactic acid cannot be converted to glucose to give you energy. So no gluconeogenesis because there is no NAD. Okay, so if you see, a lot of the mechanisms over here are linked to your diabetes lecture. Okay, so if you have understood the mechanisms in the diabetes lecture well, this will become much more easier. All right. So firstly, no energy production via fat because less fatty acid oxidation, so no beta oxidation happening. All right. Second, you would have say in a healthy individual, you would have, say, taken your proteins and your, say, fats and your lactic acid, and you would have done gluconeogenesis to give you glucose. This glucose would then help you to say give you energy by going in the ATP cycle. But no, your lactic acid cannot go like that because it doesn't have NAD. All right. The last thing you have over here is low blood sugar levels. Predominantly, you have low blood sugar levels in this individual because of low caloric intake. All right, because they are substituting eating for drinking. Okay, so a lot of alcohol intake, less food intake, less calorie intake, therefore low blood sugar level. But the other reason why you have low blood sugar level, as I said, firstly, the metabolism of liver is impaired. You do not have gluconeogenesis happening to, say, produce glucose and therefore increase your blood level. And therefore, there is like not much the liver can do. Glycogen stores obviously are exhausted because the caloric intake is so low that whatever glycogen was there, that was converted to glucose, and that's about it. You know, there is only a finite proportion of it. So that is not there, and gluconeogenesis cannot happen. You're not eating enough, therefore you have low blood sugar levels. Okay, so makes sense. So there are such multiple mechanisms which are going on. Okay, so yes, at the end, this is also in summary leading to the second stage of, say, alcoholic liver disease, which is alcoholic hepatitis. All right. Now you have the third mechanism which is happening simultaneously when an individual is drinking alcohol chronically, okay, is an alcoholic for, say, a long period of time. This leads to intestinal changes. So why do you have these intestinal changes of the intestinal lining? Because alcohol is a very inflammatory product. Okay, it's not going to be so soothing on your intestinal lining. You can feel the burn when you're drinking alcohol, right? So yes, it's a very inflammatory product, so it will cause inflammation of the lining. All right. This inflammation of the lining over a prolonged period of time, because of the quantity of alcohol consumed and the duration, this will decrease its digestion and absorption of nutrients. All right. And then what will happen? Then you will have the other thing which alcoholics do is they would replace the food with alcohol. So yes, of course, you have overall low nutrient intake happening. All right. And low nutrient intake is particularly of, say, micronutrients. Okay. So obviously, they wouldn't be thinking of having, say, fresh fruits and veggies at that time, okay, with their alcohol. All right. So yes, you have hypovitaminosis, especially of your B complex vitamin, and particularly of B1, which shows critical signs of Wernicke-Kornikov syndrome with your B complex, particularly B1 vitamin. Okay. So this is part of your food science when you may have learned your vitamins and minerals. So yes, one of the classic, say, deficiencies, B1 thiamine deficiency sign is Wernicke-Kornikov syndrome, okay, or Wernicke's encephalopathy. All right, so you have those pin pricking sensations, and then you have these funny gait when they are walking and all. That is all because of B complex, B1 deficiency, thiamine deficiency. Of course, you also have mineral deficiency. So firstly, all of this is happening overall because, yes, you have low nutrient intake because of low caloric intake, low food intake. Secondly, you have impaired digestion and absorption. So firstly, very low intake. And on the top of this, you do not have a lot of digestion and absorption happening because you have the inflamed intestinal lining. Okay. So yes, all of this together is leading to the second stage, which is called alcoholic hepatitis. All right. Okay, so yes, this was your main mechanism. All right, for this lecture. No, you have one more, so I'll just mentally prepare you. Okay, you have one more coming. All right, so yes, so alcoholic hepatitis, where you have inflammation of the liver cells, all right, due to alcohol intake. That is what the definition means. And one of the big clinical signs of alcoholic hepatitis is the stage 2 is hepatomegaly, meaning the liver becomes big in size, all right, because of the inflammation, nodulated structures. So yes, so it gets enlarged in size. All right. If you do a blood test, what is generally seen is your excessive enzymes, which is alanine transaminase and aspartate transaminase. So your AST and ALD, yes, you have to remember these names. Okay. So these are most commonly done. And if you're working as health professionals, these ALT and AST, the say the hepatic expert, the doctor, all right, or whoever is in charge, they will be asking for this test. All right, so you will be having this in your biochemical results. So yes, therefore you need to know these names. All right, so why do you have high amount of levels of these enzymes in your blood? Is because when your liver is not functioning well, your liver basically what it does is that when you have necrosis of liver cells, breakdown of these liver cells, these enzymes are released into the blood in large proportions. Okay, and therefore you have high level of ALT and AST, which is one of the big clinical marker that something is not going well with your liver, and then you may be required to do a lot more tests, all right, such as biopsies and PET CT scans and things like that. Okay, so you have another type of, say, big 4-dimensional sort of a scan, which is called PET CT scan and things like that. All right, then you have high serum bilirubin level. So now why do you have high serum bilirubin level? Is because firstly, as you know, that in your red blood corpuscle RBC, you have the hemoglobin which is sitting. Okay, so yes, when your say RBC is say old, okay, and your RBC is broken down, when the hemoglobin protein breaks with it, okay, this releases the bilirubin. All right. So yes, when you have, you know, when your RBCs are going to die and when they are expiring after their 120 days of life, okay, that is when basically this bilirubin is released from the hemoglobin. All right, it is reddish yellow in color. So healthy liver, what it does is that it mixes this bilirubin with the bile which the liver produces, and then this is thrown out in stools and in feces, and therefore the feces is, say, that clay brownish sort of color. Okay, and a little quantity even in urine, and therefore that is what gives the pee the yellow color. All right, so yes, then what happens over here is when you have excessive amount of bilirubin, all right, which is say not mixed with bile and things. Why? Because bile is hardly produced by the liver. The liver is say suffering. It is in the second stage alcoholic hepatitis. All right, so you have all of this free bilirubin which is floating in the blood. Once the blood is saturated, then it starts going into the pee, and this excessive bilirubin in the urine is the one which causes the urine to be milky tea in color. Okay, so it's like if you add milk to tea, the kind of color it becomes, similar to that. All right, so again, say a bit reddish brownish yellow. And then you have all this excessive bilirubin, all right, in the blood. That is what gives the skin, because you have depositions, then that is what gives the skin yellowish in color. So when you look at the patient's conjunctiva, all right, that would be yellowish in color. Then the skin would be very pale and yellow in color, and that is what is called as jaundice. You know how you may have patients who say that, oh, I have jaundice. Now remember, Jaundice doesn't always mean it happens because of, say, alcoholic liver disease. Even if you have, say, any other specific type of liver disease, or say your liver is just impaired, okay, this can lead to, say, bilirubin not being mixed well with bile, and therefore the individual suffering from jaundice. So there are various reasons for jaundice, okay, but jaundice is also one of the clinical signs and symptoms of alcoholic liver disease. So don't get that wrong, okay? So you may have jaundice because of multiple reasons, one of the reason being alcoholic liver disease. All right, so I hope it makes sense, guys. So these slides are pretty simple. Then you also have coagulopathy happening in liver conditions, especially in this stage 2. Okay, so again, you know, liver is the site for blood clotting proteins. All right, so now basically for healthy individuals, for you and me, liver will synthesize a blood clotting protein. If we have any cut or wound, we will have a healthy blood clot and we are fine with it. So now coagulopathy is happening. So what is coagulopathy? When you do not have sufficient amount of blood clotting, where the individual is bleeding a lot, and they may, this can even be, say, threatening, life threatening, okay, especially internal bleedings. All right, so if you have an internal wear and tear in the body, and if you do not have, say, healthy blood clotting happening over there, then it can lead to a lot of bleeding. Okay, so yes, with coagulopathy, you have greater risk of internal bleeding, all right, and this can be life threatening. And the other thing which, again, the liver does not, say, not liver, but in overall, say, the alcoholic liver condition, what you see is that you have vitamin K deficiency. Of course, the first thing is because of diet, that they are not eating well. Where would they think of eating, say, spinach and your kale for their vitamin K? No, but the other thing which you have, the K2 vitamin, okay, which menaquinone, the K2 vitamin, which we can synthesize in as humans in our large intestine by the fermentation of the bacteria. This also does not happen because, as you know, the intestinal lining are suffering because of inflammation, because of all that alcohol intake. All right, so you have poor production of vitamin K internally as well, which we are able to synthesize, that is impaired. And you know, vitamin K is super empirical for, say, the blood clotting process. But now blood clotting, firstly, the proteins are not there, blood clotting proteins, and now you have vitamin K deficiency. Obviously, you are at a very high risk of, say, internal and external bleeding, excessive. All right. So yeah, I hope that makes sense. Now, this is important, guys. Again, in alcoholic stage 2, which is you have the alcoholic hepatitis, what you will see is portal hypertension. All right. So I just wanted to show you the portal veins first for those who are not aware. So you look at all of these blue color veins. All of these blue color veins are called as portal veins. They basically connect all of your other organs to your liver. Okay, so the main connection pathway between your various other organs, like your small intestine, large intestine, pancreas, even you have spleen, which is not in this diagram, but just think there is. Okay, so all of those, and obviously your stomach also, all of these are connected to your liver by the main portal vein. All right, it's called as portal hepatic duct. All right, so yes, so you have this portal venous system. Okay, so again, guys, this is the main, say, mechanism of portal hypertension, which we are going to be speaking about. So basically in the alcoholic liver disease, in this, what you see is portal hypertension. Okay, so hypertension, particularly in your portal venous system. Okay, so hypertension in these blue color veins, basically, is what we are saying. All right, so this is the mechanism which we will be talking about. And again, this is how you would be, say, asked to write in your exam if you were given this question, for instance. But again, I have broken this down so that it's easier for you to understand. So we'll be looking at, again, this side, then we'll be looking at this side in a different sheet, and then we'll be looking at this one. Okay, so when I talk about it and when you look at this diagram at the end, it will all make sense to you. All right, so yes, the first thing which we talk about is that in alcoholic hepatitis, which is your stage 2, all right, what do you see are signs of portal hypertension? All right, so what is portal hypertension? It is hypertension in the portal venous system. What is portal venous system? It is those network of veins which are connecting your various organs to your liver. Okay, and this is my shorthand for my organs. Okay, so I have stomach, I have intestine, small and large. Then I have pancreas. This is my pancreas. And this is my spleen. Okay, this bow looking thing. I had to make something up, so I just made this. All right, so basically, yes, these are your, say, vital organs, and they are connected to your liver via the portal venous system. So you have hypertension within the portal venous system. Why do you have hypertension within the portal venous system? All right, because of inflammation. All right, so there are multiple reasons. The first biggest reason being is because of inflammation. All right, then you have fibrosis. All right, and then you have nodular hyperplasia, which is increased number of cells. So basically, guys, as you know that your liver is has become into a nodulated structure, okay, at your stage 2. All right, now this is impacting even the portal venous system. All right, so the cells are becoming nodulated. When the cells become nodulated, they become very clumpy, and I think it shows you in this diagram. No, this looks like a very nice healthy liver. I have one more diagram in the coming soon, and you will see, obviously you have seen those real life, those real picture diagrams in your pre-readings, where you can see how clumpy and nodulated the liver becomes. Okay, so yes, so even in the portal veins, the cells start becoming nodulated, and the cells start growing in abdominal numbers, so hyperplasia. So you have nodular hyperplasia, which is abnormal cell growth, okay, within your portal venous system. So now you have all of these excessive cells within your portal venous system. Now remember, these are tiny delicate veins, okay, so this is going to block a lot of area. All right, this is going to reduce the diameter of your portal veins. All right, and fibrosis, why? Because what's going to happen is all of this blocking and this inflammation will lead to, say, death of the say of parts of your portal venous system, okay, which is necrosis. And on the other hand, you have fibrosis, because what the portal venous system will try doing is, like, when you have necrosis happening, you have scarring of tissue happening. So basically, you know, like if you had, say, a surgery, or if you have had a scar, then you have the scar tissue remaining, the mark remaining. So imagine, so a lot of cell death going on, a lot of inflammation going on, a lot of nodular hyperplasia going on. This is leading to scar, say, tissues or scar areas within your portal veins. Okay, so basically at the end, what is the conclusion? This is decreasing the diameter of your portal veins. All right, and you know, in the CVD lecture, when the diameter decreases, what will happen? You have very, very less area for the blood to pass to the other end, and therefore it will pass with a lot of pressure, and this may lead to, say, bursting of your portal veins. All right, or else what may happen, you may have these say, because it leads to bursting, then your body will try to form a blood clot over there. The clot will, say, get ripped off, embolism, if you remember in CVD, right? Then it will get stuck in some other part of the portal vein, and what will happen? You won't have blood flowing on that side, because there's a clot stuck on this side, so you'll have necrosis of that part. All right, so basically the same kind of mechanism which you have for your atherosclerosis and CVD, that is what happens in hypertension even over here. Okay, so you may have ruptures, you may have clot which are stuck, and therefore necrosis, all right, of parts of your portal venous system. Okay, so on the other hand, what the body tries to compensate because of the hypertension is because, as you know, that the diameter has reduced and the blood is flowing with a lot of pressure. These portal veins, they try to enlarge, they try to swell up. Okay, so they try to increase their surface area, but as you know, you can only increase your surface area so much. All right, and the importance of this I explained to you in your CVD lecture when I talked about osmosis. All right, so you can only do so much of stretching. All right, so yes, you have swelling, you have enlargement of your portal veins, but that is only so much you can do. And this swelling and enlargement of your portal vein is called as varices. All right, so yes, you have varices happening. Then what is the other thing? So yes, you have swelling happening, but you can only swell and expand your surface area to so much. Of course, you will be having ruptures, and then you will be having, say, trying to form clots, but not really efficient in it. All right, so you will have a lot of bleeding, a lot of them ruptures, guys. You don't even have, say, enough amount of, say, these blood clotting proteins to really give you these blood clots, healthy blood clots to, like, say, sew up your portal veins again. That really doesn't happen. You have a lot of ruptures happening because they are swelled up to such a consistency. Okay, so yes, then you have, say, at the end, what is the result? You have high, say, portal hypertension, you have high coagulopathy, and high coagulopathy meaning you have less blood clot, okay, because that area is not getting stitched back. All right, so yes, you have high internal bleeding because of this, and this internal bleeding can be life-threatening because your portal veins are not like just, say, one little vein which is connecting the organs to this. It is like a mesh, a network of system which is surrounding all of these vital organs. Okay, so yes, therefore, if you have this mesh network of system being damaged, meaning that is really life-threatening. Okay, with damage meaning internal bleeding. All right, so life-threatening that yes, the individual can die. Okay, and unfortunately, because of coagulopathy, very difficult to stop the bleeding also. Okay, so that is your, say, one mechanism. Now, the second part of the mechanism is that just like how it happens, because you have high blood pressure, which is hypertension in the portal vein, what the body does is it tells your, say, system to release vasodilatory factors. Okay, so what are your vasodilatory factors which are being released? They are nitric oxide, they are specific eicosanoids, and you have two important types of factors which are being released. They are called as vascular endothelial growth factor and basic fibroblast growth factor. Okay, all of these factors are vasodilatory in nature. All right, so meaning their main function is, let's dilate the portal vein. You would think, okay, now they will dilate the portal vein. That is great. End of story. No. Now remember, guys, how the body does not compartmentalize things. When you have vasodilation happening, it not only dilates the veins of your portal venous system, but it causes systemic dilation of your blood vessels, meaning of your arteries, of your capillaries, everywhere. All right. So you do not have very targeted dilation. It is not dilation only of your portal venous system. It is dilation which is happening, say, systematically in your body. All right. So because there is a systemic dilation happening of blood vessels, one particular thing which also gets dilated as part of the systemic dilation is your splenic arterial vasodilation, meaning it dilates the blood vessels which are surrounding your abdomen. All right. And what are the blood vessels which are surrounding your abdomen? Basically, your peritoneal membrane. So your peritoneal membrane is, say, like a shopping bag. Okay, so think of a Woolworths plastic bag, all right, so which you get from Coles and Woolies. So you have this plastic bag which is called as peritoneal membrane. All right, now this peritoneal membrane has a lot of blood vessels which are attached to it. Okay, so you have this sac, all right, and this sac has a lot of blood vessels attached to it. These blood vessels are dilated now. Okay, so their surface area has increased. This is called as splenic arterial vasodilation. All right. And now within this sac, you have all of your intestines which are sitting. Your small intestine, your large intestine are within this plastic bag. Okay, this plastic bag is called as peritoneal membrane. You have a lot of blood supplied to this peritoneal membrane from various blood vessels. These blood vessels are all getting dilated because of these vasodilatory factors. Okay, so vasodilation is not just pertaining to your portal veins, it is everywhere, unfortunately, okay, including your splenic arterial vasodilation. All right. Okay. So then what happens? Now you know all of your blood vessels are dilated, okay? And this your body registers as low blood pressure, that the blood vessels are getting dilated, the blood volume is going down because there is so much of surface area. Okay, so yes, your blood pressure goes down, blood flow goes down because of vasodilation, this will activate the renin-angiotensin mechanism, because you know the first thing which gets activated when there is systemic low blood pressure is the renin-angiotensin mechanism. All right, the body never meant to do this, guys. If you see, okay, the body just wanted to do vasodilation in the portal venous system. But when you have these vasodilatory factors which are released, you have vasodilation happening everywhere, okay, in random parts, like, you know, your splenic arterial vasodilation. All right. So yes, so basically, unfortunately, you have vasodilation happening everywhere. Blood pressure is going down. Renin-angiotensin mechanism activated, because of which you have sodium and water retention. Now you have all this sodium and water retained. What happens is that the sodium and water is attracted to your peritoneal membrane, because you have, particularly you have, say, a big amount of vasodilation happening in your, say, the peritoneal membrane, the splenic arterial vasodilation. So a lot of water and a lot of sodium is stored in your peritoneal membrane. Okay, this gives a pot belly appearance. All right. So beer belly is different. Okay, so please understand, beer belly is abdominal obesity. That's just fat. Okay, but this is water retention or edema. Okay, because of this mechanism. All right. So the pot belly, which individuals suffering from alcoholic hepatitis experience, that is because of edema, because of the renin-angiotensin mechanism that has been activated, secondary to the release of vasodilatory factors, whose actual intention was to only dilate your portal venous system veins. All right. So I hope this is very, very clear, guys, because as I said, these mechanisms are new, but they are very important, especially if you're going to work in clinical settings. All right. So now we'll be moving forward. So the last thing over here is that, yes, you know, liver synthesizes albumin, okay, your blood cells, but now you have very poor synthesis of albumin because the liver is not functioning well. This causes increase in oncotic pressure. So basically the word oncotic is like osmosis. Okay, so you have an osmotic imbalance, but when this osmotic imbalance is because of or secondary to protein imbalance, this is referred to as oncotic pressure. Okay, so you have osmotic imbalance because of protein. This is called as your oncotic pressure. All right. So yes, so over here you have an increase in oncotic pressure, meaning you have less solute, which is, say, less protein. All right, and you have more solvent. Okay, you have more fluid, and all of this extra fluid, unfortunately, is also because we saw in the last slide, you have the renin-angiotensin mechanism which is running, so it is accumulating a lot more of, say, water, a lot more of sodium, and now you have less protein. Okay, which is leading to edema, further and further amount of edema, especially where is that edema? That edema is, say, in your abdomen, in your peritoneal cavity, okay, the plastic bag which is surrounding your intestine. All right, so this basically, this pot belly, this fluid retention, which I'm calling edema, the actual scientific correct term for it is ascites. All right. So basically you refer to edema when the retention is, say, more in your hands, legs, feet, and all of that. But this particular retention of water in your abdominal membrane, that is called as ascites. All right. So yes, guys, now I can assure you that your big mechanisms are over. All right, for this, this lecture. All right. So now you have two little tiny mechanisms only, which is fine. Okay, sorry I keep moving so much, is because it's difficult to just sit and give lectures. Okay, so I would love to have a standing desk at home, but yeah, I'll buy it when I buy it. All right, so right now it is this. Okay, so yes, you may see me I'm moving and shuffling a little bit, but it is, yeah, because of this. All right, so I hope that's all right. Okay, so yep, so now we'll move on further. All right, so I just wanted to show you varices, guys. So as I said, varices means what? Varices means when you have swelling, enlargement of your portal venous system. All right, because of that, say, portal hypertension. All right, and hypertension is because of all those reasons which I told you: inflammation, necrosis, fibrosis. All right, and you have hyperplasia. All right, nodular hyperplasia. So the swelling of your, say, portal venous system, it looks like this. Okay, so this is how they swell up, and then they can swell up no more and they burst, and then you have a lot of this internal bleeding happening because of, say, low coagulopathy. The individual can also die. Okay, so you see now over here how the liver looks. It looks so clumpy. All right, so this is the nodulated liver structure. Okay, so liver with cirrhosis. So cirrhosis is stage 3. We will go to that. All right, so basically this is how the liver looks. It looks really clumpy. It doesn't have a good functioning. All right, this is your main portal venous duct. Okay, so which is, say, all of these tiny little portal venous system, they are connected to the portal venous duct, and this duct is the one, you know, which is connecting it to the liver. All right, so yes, so you have inflammation, necrosis, and hyperplasia of all of this, you know, these portal venous system. All right. So guys, these are the various stages. Okay, I should have said, I'll just say, you have a medical image now, so caution. I know it's too late, but I forgot. Okay, I'm so used to medical image that I don't think twice, but I understand that most of you are undergraduate and maybe you're not used to it. So, well, you have a medical image ahead. All right. So now we will be looking at a medical image. Okay, I think that's enough caution. All right, so guys, basically say this is, say, a endoscopy of your esophagus. Okay, so esophagus. All right, so and these are your blood vessels which are, you know, surrounding your esophagus. Okay, so this is a healthy one. There is no varices. You have grade 1 varices, grade 2 varices, and grade 3 varices with a lot of internal bleeding. All of these red spots, they are these bursting of these varices and lot of internal bleeding. Okay, and as you can see, there is a lot of swelling which is going on as well, and you can see the constriction happening as well. So guys, from a dietary point of view, it's so difficult to feed these individuals because they sometimes they are just on liquid diet, or sometimes you just can't use their esophagus anymore, and then you try to have, say, enteral feeding. Okay, so tubes, say, nasogastric or dietary directly in your, say, duodenum or jejunum and things like that. But because they are at such high risk of internal bleeding, even that is very critical and say very worrisome to, like, say, make a enteral feeding, say, insertion in these individuals. So it's a very, very say, serious condition. Okay, when you are reaching this stage of alcoholic liver disease. All right, so now moving further. So guys, this is what I wanted to show you, spider angioma. So do you see these ones? So for instance, these vascular endothelial growth factor and basic fibroblast growth factor. So guys, this, as I said, causes vasodilation everywhere, right? So one of the places it causes vasodilation is the blood vessels which are right under your skin. These are vasodilated. Okay, when they become vasodilated, they you can visually see them very easily, and this is how they look, like a spider web structure. Okay, so it is like it looks basically like a dead spider, which is, say, yeah, squatted with your shoe or something, which is sad. But yeah, this is how, basically, this is spider angioma. All right, so this happens because there is vasodilation of these blood vessels. Okay, and it is because of those two particular main factors. Okay, they are responsible. All right, so now moving further. So guys, this is the last thing. This is how ascites looks. Okay, so you have, say, a lot of fluid retention in your peritoneal membrane, your peritoneal cavity. Why? Because of splenic arterial vasodilation. All right, so a vasodilation of the blood vessels which are surrounding your peritoneal membrane. All right, that's why you have easy fluid retention over here happening. Okay, therefore the pot belly is not fat. It is actually ascites, which is say, edema, okay, of your abdomen. Okay, so yes, but the correct terminology is ascites. Please don't say edema. That was just for me to explain it to you. All right. Okay, so guys, all of these blue slides are again everything which I have just explained to you. Okay, so it is just, say, I've written it down for you because these are very unique mechanisms which you may not have been exposed to. Okay, guys, the other thing which you see in your stage 2 of alcoholic liver disease, which is your alcoholic hepatitis, the other thing which you see is you may see hepatic encephalopathy. Okay. So now there are two theories for hepatic encephalopathy. Basically, encephalopathy has to do with neurocognitive disorders. Okay, so now, as you know, your entire GI system is affected because of the varices, because of the ascites. You can hardly eat anything because of all the constriction that has happened. Okay, so digestion absorption obviously is impaired anyways. So your, say, your entire GI tract is disturbed, and now you have neurological impairment as part of this condition as well. So imagine the repercussions of, say, drinking so much of alcohol. All right, they are scary. All right, so don't drink so much alcohol. Okay, so yes, so what is the theory one? So the theory one says that when you have, say, wear and tear of your, say, intestinal cells, okay, so as you know, intestinal cells are essentially protein. Okay, so when you have protein breakdown, you have release of ammonia. Okay, you have release of ammonia also from all of these, say, bacterial fermentation going on, all right, in your large intestine. So yes, your bacterial fermentation in the large intestine, that is releasing ammonia. Then you have breakdown of your cells, okay, which could also release ammonia as well. All right, so this is just a normal regular wear and tear of your intestinal cells, okay, which happens with all of us. All right, but we have the capacity to flush out that ammonia, whereas these individuals don't. All right, then you have, say, your muscle breakdown, which is your muscle breakdown wear and tear, cells of your muscles breaking down. All right, this is predominantly more seen in alcoholic liver diseases. Why? Because of malnutrition. As I said, they substitute a lot of food for alcohol intake, and you know, alcohol does not give you any energy. So your muscle starts breaking down to fuel your body. Okay, so it is breaking down vital protein to fuel your body. And as you know, when you have protein breakdown, you have ammonia release. So you have, say, natural wear and tear from the intestine. Therefore, you have ammonia release, bacterial fermentation in the large intestine, which is again releasing ammonia, muscle breakdown because of malnutrition, the alcoholic liver disease associated malnutrition, therefore ammonia release. Then of course you have your kidney byproducts, okay, which also like give you ammonia. All right, so now what is happening at the end? For healthy individuals like you and me, we have no problem with ammonia because our liver, it converts the ammonia into urea. This urea is then eliminated in the urine. Okay, but now with liver impairment as seen in alcoholic liver disease, all right, then what happens? You do not have this conversion of ammonia into urea. All right, so then what will happen? Then you will have this ammonia which goes to your muscle, which goes to your brain, and this ammonia is converted into glutamine. All right, so now high glutamine levels in the brain, what does it do? Okay, so now imagine you have a lot of ammonia which is floating in your blood. Okay, some is entering your muscles, some is entering your brain, but your brain is not used to this irregular amount of this ammonia. This is too much for the brain to handle. Okay, so brain is converting all this into glutamine, which is not healthy for us to have so much amount of glutamine in our brain. All right, so then what happens? Because of high glutamine, you see signs and symptoms such as impaired neurological or neurocognitive functioning. All right, why? Because glutamine induces inflammation. So when you have a lot of glutamine in your brain, which is not healthy, this leads to inflammation because the body senses, why do I have so much of glutamine in the brain? This is not healthy. All right, it activates again your system, your immunosystem, and then you have inflammatory markers. Okay, but this is not doing any good because this is actually leading to neurocognitive impairment. All right, and the second thing, glutamine, as you know, is an amino acid. All right, so it is a type of an amino acid. Now when you have a high solute load in your brain, meaning a lot of say glutamine, and you have less solvent, this is imbalancing the oncotic pressure. All right, therefore what happens? Then you have water which is drawn into your brain. This causes cerebral edema. Okay, now for here using the word cerebral edema is right. Okay, because it is drawing a lot of, say, water from, say, outside of the, say, your systemic circulation into your brain. All right, it is even dehydrating the cells to like increase the, say, fluid level in your brain, which is what is causing cerebral edema. So you can also see actually an increase, probably say even in the skull size, not to that say great level, but you may observe it, all right, in certain individuals. But of course, with just your say scans, it will definitely tell you EEG that you have edema or not, all right. So yes, this at the end leads to encephalopathy. So this is theory one, okay, this is mechanism one. Okay, so I hope this mechanism is clear. It is very, very simple. The second mechanism is even much more simpler, which is your muscle is the main site for the breakdown of branch chain amino acid. What are your branch chain amino acids? It's important for you to remember. Whenever I ask students, 90% of them, they don't know this. Okay, look up what are your branch chain amino acid. I'm not going to give you the answer. All right. Then you have your liver. Your liver is the key principal site for the breakdown of aromatic amino acid. Yes, you should be knowing what are your aromatic amino acids as well. Okay, so if you don't know, Google it up. All right, you should know what are your branch chain amino acids, your aromatic amino acids. Okay, so yes, in liver condition, because the liver is impaired, it is not working well, you do not have breakdown of aromatic amino acids. Okay, so in the blood, your aromatic amino acid concentration goes up, branch chain amino acid concentration goes down. All right, these aromatic amino acid, they cross the blood brain barrier. Okay, they go into your brain. All right, and they cause the same type of things, meaning they will trigger inflammation. All right, they can also like trigger cerebral edema. All right, and this can cause neurocognitive issues, which leads to encephalopathy. So encephalopathy essentially is what? Neurocognitive issues. All right. So this is again everything explained to you in say in written form. Okay, and guys, these are just FYI 4 stages of say encephalopathy. As I said, encephalopathy is nothing but neurocognitive issue, starting from very mild symptoms such as say confusion, decreased attention span, all of that, and then leading to coma, all right, and death. So that's the worst thing. Okay. All right, so guys, the last stage of liver disease is cirrhosis. So now guys, all the mechanisms that we have studied, each and every one of them, coagulopathy and portal hepatic, say hypertension, and then the 3 mechanisms of alcoholic liver disease, each and everything is happening over here in cirrhosis, but everything is happening in a more aggravated form. Okay, so that's the only difference. Okay, cirrhosis has nothing new to offer. Enough damage has happened in your body. Everything is just happening in a more aggravated form. So for example, if your varices is at stage 2 in your say alcoholic hepatitis, now over here it is in your stage 4, the last stage, okay, which is so difficult to manage then. Okay, so everything aggravated form is cirrhosis. All right, so now this entire say thing is your pathophysiological mechanisms behind your liver disease.